You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 449 of the podcast. And in this one, I chat with Dr. Stephen Phillipson. Stephen is a licensed clinical psychologist who specialises in CBT for OCD. Stephen is the clinical director at the Centre for Cognitive Behavioural Psychotherapy in New York. And in this episode, we discuss figuring out what's the problem in OCD, defining what a problem is, anxiety versus worry, what gets in the way of OCD treatment, the issue of seeing thoughts and feelings as the problem, judging thoughts as bad, and much more. And thank you to NoCD for supporting the podcast. NoCD offers effective and convenient therapy available in the US and outside the US. To find out more about NoCD, their therapy plans, if they currently take your insurance, or to download their free app, head to go.treatmyocd.com/the OCD stories, or the link will be in the episode description. Thank you to all of our patrons for supporting our work. To sign up to our Patreon and to check out the other benefits you'll receive as a patron, please see the link in the show notes. So thank you so much to Steve for his time. As always, I appreciate it. And of course, thank you to you guys for listening. Without further ado, here is Steve. Welcome back to the podcast, Steve.
Always good to see you, Stu. It's been a while, but always nice to be back.
Yeah, it's good to have you back. So just firstly, how you been? Any news or anything you want to share?
Enjoying the summer. Sad that it's coming to an end, but enjoying the boat. Hopefully you and Punim and the kids can come out and enjoy it soon.
Yeah, one day definitely. On a not so windy day, but today I definitely felt the weather was changing. Like it was the first day that I had generally had to have a coat on this summer. So
a coat, really?
Well, I had a gilet on, but do you call that in America gilets? Is that the?
Never heard of that term.
The coat without the sleeves, like a vest.
Oh, a vest. We just call it a vest.
Oh, right, okay, gilet. I guess it's French. I had to wear that. So a bit sad, but nice crisp cold air, which is also good. Anyway.
This is why you Brits don't believe in air conditioning, because according to you guys, it's only really warm for 2 weeks. Other than that, it's beautiful weather.
Yeah, it's been about 3 weeks this year. So
3 weeks because of climate.
Yeah, true.
Right.
Cool. So today's topic, what we're going to be discussing?
Today's topic is titled, "What's the Problem?" And it's really about how persons with OCD, they tend to react to situations within their own mind and body as if there is a problem when there is not one. And they try to resolve non-problems in a way that creates problems. So that's today's topic. I wanted to pull a little bit of what we call here in the colonies a fast one on you, Stu. I know you always love asking me questions at the end, which always catch me off guard. But I'm going to ask you a question just to start. And I'm going to ask you, if you don't mind, how do you define the word problem? It's a very complex word if you think about it. How do you define the word problem?
I'm just going to speak and see what comes out. A problem is an issue facing someone that they may not know how to work through it.
So if I have an issue like how to fix my bicycle and I don't know how to work through that would then be a problem?
Yes, but now that you say that, because I did have an issue with my bicycle recently, which was a problem, but then I knew I needed to just take it to the bike shop and I knew they would fix it. So I guess I knew the solution to my problem. So I guess it's just something that gets in our path of life, whether we know how to get around it or not. It's the thing that temporarily at least blocks us.
I think, because I've been giving a lot of thought to this concept of what is a problem.
Hmm.
There's I think most problems we see as pending, meaning we see the potential for a, let's say, catastrophically negative outcome that we feel compelled to resolve. And I think that problems create a very significant negative disruption to the quality of our life and to our freedoms in living our life.
Hmm.
But it is a very complicated issue because, what I might define as a problem, someone else might see as something that's completely not a problem.
Hmm.
So I think it's a very relative term and concept. And in a way, that creates some of the foundations of, how OCD sufferers encounter things that they define as a problem, which may not be. But because they define them as problems, it actually has a biochemical effect on the brain to create more of an emotional distress signal that alerts people to the idea that there is a problem and that that problem needs to be, kind of imminently resolved. It's sort of one of the interesting ways in which we define anxiety from worry, which is a very, very important distinction, because anxiety compels sort of an immediate resolution, where worry sort of has more of a, let me think about it a lot, see if I can find the answer, see if I can get control of a situation through giving contemplation to it. And so, anxiety creates, this very, very high pressure to seek safety. And the reason something is called anxiety is because inherently it's defined as being irrational. And that's kind of interesting because it's not that we have anxiety about being bitten by a snake. We actually have fear of being bitten by a snake. Fear is a rational threat of something that might be harmful, whereas anxiety is always an irrational threat from something that is actually not harmful or problematic. So, what I want to do is talk about within OCD, how people see their brain's activity as problematic. And so the first thing we think about with OCD, I believe, is people identify and focus on this thing called an intrusive thought. Some people will feel the experience of distress first biologically, but for the most part, people look at OCD as the threatening thought, then the emotional distress that gets paired with it, and then these activities to undo the thought. So obviously, the intrusive thought, can represent things like, uh, you know, germs that might be harmful. So germs might exist on a doorknob, germs might exist on a toilet seat. For people with OCD, the most well-known and publicized theme of OCD is this idea of, people who are what are called germaphobes, people who are anxious and phobic about germs being a threat to themselves. Sometimes people have thoughts or experiences or concerns about the germs being a threat to sort of innocent others also. So the initial part of OCD is this idea of the intrusive thoughts. I might get sick from touching a doorknob. I might get sick from touching my shoes. I might get sick from touching a toilet seat. Maybe the stove is still on and I need to go check. Maybe the light isn't completely off and I need to check the light. Maybe the faucet isn't off and it might cause a flood. I need to go check the faucet. So there are these intrusive thoughts that tend to pair up with this illusion of there being a problem. A flood might be a problem. Fire in your house, most people would consider a problem. Or getting sick and dying, most people would consider a problem. And as you're aware, my focus, but certainly not sole focus, has been on the concept of intrusive thoughts being not so much those that compel a behavioral undoing, but a cognitive undoing. So I referred to that in like 1992 as pure O. And so there people have thoughts where their brain, the machine, creates thoughts of maybe doing harm to others. Um, the big three are thoughts about inappropriate sexual content, inappropriate religious content, or inappropriate harm content. And so here, along with the sort of classical OCD themes, people most often look at the brain's activity in terms of generating the thought as being the problem. And the most common misconception and the most common disruption to effective recovery is when people and even mental health professionals see the thought content as the problem, as something that should cease and desist, go away, and so like a thought of harming my children. If I'm like, okay, what can I do to get my brain to stop producing that? Obviously, that's going to entail a lot of wasted effort in trying to control the brain. And once again, the effort to try to turn off the independent system of the brain and creating these natural human associations can very much create a problem. So first and foremost, one of the most important misconceptions is this idea that the thoughts are the problem. And even recently, unfortunately, people are starting to look at the themes within the thoughts in terms of like um, trying to decipher underlying issues related to the thoughts, or trying to figure out the core fear related to the thoughts. And I think these types of approaches create a lot of misconception about giving relevance to the thoughts when actually within the paradigm of treatment, the most effective methods involve conveying irrelevance and disengaging from efforts related to the thoughts. So the first component of OCD that people believe are problematic are the thoughts. The second component that people believe are problematic is generally the emotional component that accompanies the distress. So I have the thought of harming my children. I have the thought of catching AIDS from a doorknob. And now my heart is racing. My stomach feels nauseous. My head feels very tight. My chest is tight. I feel very dizzy. And I'm reacting to my bodily sensations as if something clearly unique is happening, unusual is happening, but now I'm defining these bodily sensations as, once again, a problem. And I think that, a problem for most people is defined as something that we need to seek relief and escape from. And once again, that's the foundation of OCD, and that's the foundation of how OCD becomes problematic, because it's within the desperation and the anguish over a person judging themselves for having these intrusive thoughts or engaging in hours and hours of life-wasting rituals to either eliminate the distress through washing, through avoidance, through mental checking and reassurance seeking on the internet. Um, these are where the problems from OCD come into the picture. And so, um, the third component within OCD is obviously the way in which people manage part A, the intrusive thoughts, part B, the emotional behavioral, the emotional physiological component, and the third being generally the efforts to either avoid the triggers or engage in behavioral rituals to undo the threats or the incredible amount of wasted time associated with figuring out whether or not this intrusive thought means something negative about me as a person, or it might say something about my susceptibility, my capability of acting in a way that would be problematic for myself or others. Any questions at this point, Stu?
No,
Comments?
just to add around the emotions. Obviously, you talked a lot about anxiety, but obviously guilt, shame, disgust also can come in there.
Yeah, yeah, absolutely. That was definitely on my notes for the future. Um, One component of OCD that is problematic. Once again, it involves a great deal of misinformation that people have about their brain's activity. Is the idea that their thoughts are not normal and therefore they have a problem. Their thoughts are out of control and therefore they have a problem. It's still shocking to me when I hear people say that they feel that they're responsible for their thoughts. This is a huge problem in what makes recovery complicated and delayed is this, misconception that the activity within our brain is A, a representation of our character, or B, something we should be able to control. And so people tragically think when their brain is acting in this independent way, that means something's wrong with them. And once again, seeking to try to control one's brain's activity wastes a lot of time, and it's a completely fruitless activity because, as you may be aware, that's not really possible. The brain is made up of at least two components in regard to thought. The machine component, which generates thoughts completely spontaneously, completely independently of any of our control or choice, or even as a representation of our character. And then there's our ability to have a relationship with the brain activity. And so, and this is where people really get very, very confused in terms of this distinction and differentiation between the brain activity and how they can relate to it. Most people who have OCD relate to the brain activity in a way that pathologizes it. If I have a thought of harming my kids, oh my God, I'm a horrible person. If I have a thought of harming my kids, oh my God, they may be at risk. I need to make sure that they're not. And so this concept of substantiating the brain's activity is once again really at heart of what is the problems within OCD. And this kind of speaks to my original point in terms of like the thoughts, once again, are not the problem. The feelings, although they feel very, very threatening, having a rapid heartbeat, feeling nauseous, feeling dizzy, these things make us feel like we're going crazy, we're dying, we're having a severe negative reaction, and we should seek relief. But once again, this second component, is a huge part of how people see something as a problem when it's actually not. And just because something feels problematic, or we look at something as a thought as problematic, by all means doesn't mean that it is. And it's so important that people really understand that difference and manage their brain's activity and their body's activity in a way that conveys that distinction. So a question, going back to our original question, what is a problem? And in a way, I think that brings up a very profoundly philosophical question. There are these people from the days in which Greece, rather than Rome, ruled the world. Greece kind of ruled the world a little bit before Rome, probably a few hundred years. And there was a subset within the Greek community called the Stoics. And they're a very, very interesting little group of people. These were people who really were like, pain is good. We grow from pain. And so one of the most famous sayings from the Stoics is, nothing is a problem unless we see it as one. And that's a very, very deep and profound concept. Many, many people would argue with that. But in a way, it talks about the relativistic nature of what we define as a problem. So Stu, do you agree that nothing is a problem unless we see it as one?
In principle, yes, but of course, my brain is always throwing up caveats, right? You know.
Oh yeah. I mean, if my uh, child had cancer, I
Mm.
probably see that as a problem, and not like, oh, it's only a problem because I see it as one. Or even if I had
Yeah.
stage 4 cancer, I'd be like, oh, but in a way, if you elevate, to a very high level, you'd say, well, life is short for all of us, whether we die, of cancer at age 50 or whether we die of Alzheimer's at age 110. It's all kind of relative. And
Mm.
there's another kind of wonderful saying that goes, rule number one is don't sweat the small stuff. And rule number two is everything is the small stuff.
Yeah.
And I think that these sayings try to kind of help us put in perspective, how to really try to dial down the way we can get very upset about systems in our mind and our body that are kind of malfunctioning and reacting out of control.
Mm.
Which brings me back to a wonderful saying in psychology that goes, don't give yourself a headache for having a headache.
Mm.
And I really, really enjoy that saying.
Yeah. Well, it's there's also, like, Kimberly Quinlan. She's talked about it ages ago on the podcast, that the whole second arrow story. So I won't go through the whole metaphor, but the first arrow hits the warrior, and that's pain. Can't do anything about pain. The second arrow hits us, and that's suffering. So suffering is a choice. Pain is not. So it's,
Right. And
yeah.
I'm a huge, someone who's in tremendous agreement with the idea. I phrase it slightly differently. I would say that suffering is the intolerance to pain. Suffering
Mm.
is the rejection of pain.
Yeah.
And I think that offers a lot of kind of kind of peaceful opportunities for humans.
Mm.
So, brings us to a question, is OCD a problem? And I can't think of a single person who has OCD who wouldn't agree that OCD is a problem. And I would say OCD is a problem. OCD tends, in the vast majority of cases, to create a tremendous disruption in people's lives in an extreme way. Um, OCD tends to promote a tremendous amount of avoidance of people's natural life path. And so things like friendships, quality time with family, and engaging in one's own kind of hobbies, these things become often sacrificed within the condition of OCD. There tends to be, hours and hours of wasted time engaging in escape rituals when someone's suffering from OCD. And keep in mind that to qualify for a diagnosis of obsessive compulsive disorder, the D represents that a person's life has been significantly disrupted. So even within the diagnosis, the idea of living a disrupted life, and we would say, living a disrupted life is problematic. So within the diagnosis, it entails and conveys the idea that yes, OCD is a problem. Um, OCD is also still extremely misunderstood. I still hear stories of people whose children are taken away because they go to a pediatrician and talk about their thoughts of harming their children, and the pediatrician did not do an adequate job of screening for, is this anxiety or is this the potential of someone to lose control? There's a tremendous amount of stigma and misunderstanding. Um, I've had a number of cases of patients who, in the hope of being, open and accepting, have told coworkers about their OCD, and then have been denied promotions and have been discriminated against in the workforce.
Mm.
So yeah, in that regard, OCD can still be a problem because unfortunately, I always encourage, all of my patients to not be disclosing within the workforce of OCD because of the stigma and prejudice and ignorance of the condition.
Mm.
And that's kind of sad, but unfortunately for now, I think it's a um, it's a realistic, um, problem to, open oneself up to that kind of judgment and misunderstanding.
Yeah, I think it's definitely changing, right? And especially, um, yeah, I think, yeah, amongst healthcare professionals, like the examples you give, I think that's definitely the exception, not the rule, but it happens, right? So it's definitely worth saying so people can be cautious about how they open up or checking with a healthcare professional whether they understand OCD first, and in detail. Um, and that's, I know,
Yeah, but
yeah,
I think,
go for it.
unless you have it or you're an expert, and I'm not sure whether you would
Yeah.
agree, but when you talk about, understanding OCD first, um, I think outside of those two categories, um, it's still profoundly misunderstood with profound amount of ignorance.
Oh, 100%. But like an example, a few years ago, I knew someone who'd given birth in the UK and they were having tons of intrusive thoughts around harm around their child. And they were in tears and stuff, and they told the midwife, and the midwife nonchalantly went, "Oh, that's just intrusive thoughts. There's nothing to worry about there." Like completely calm. She wasn't an OCD expert, but I know like Catherine Benfield, a UK advocate, had written a whole piece on intrusive thoughts for the Journal of Midwifery. So hopefully that. So there are, it is changing. Definitely in the UK, from an intrusive thoughts point of view, people are getting much more like, "Oh, it happens," whereas that wasn't the case, say, 5 years ago.
I'm
So
glad to hear that. I
yeah.
certainly hope it continues to expand, but I still think it's a kind of a dangerous roll of the dice. Whether a midwife has even read
Yeah.
that piece. In the world of what people consider problems, with OCD, people make problems or contextualize problems out of what I refer to as independent systems, which means things in our mind and body that take place without our being able to control it. You and I, had a wonderful podcast on sleep and people who have sleep disruption because they think, they need a certain amount of sleep, or waking up in the middle of the night as being problematic. And then to relate to independent systems like not sleeping for 8 hours, or being woken up, or having a difficult time getting to sleep, all of these things that we have no control over,
Mm.
that when people place the definition of a problem on top of it, it expounds the issue and expands, the degree to which a person suffers from the very thing they're trying desperately to not be victimized. Some
Just to say,
interesting.
do you know what's interesting there on the sleep podcast we did? Since with that episode, I don't, if I wake up in the night, which is most nights because my daughter will wake me up, I sleep through about 2 nights a month. So the other 28, 29 days, I used to, before that podcast, I would like check my phone, what's the time? Then I'd get annoyed, like, oh, I've only got 3 hours before I have to get up. I've only had 4 hours so far, or and then I'd wake up the next day, I'd be anxious or stressed. I haven't had enough. How am I going to help my clients? I'm too tired. Da, da, da. Now I never check. I never look at the time because it is what it is. I've either got enough sleep or I haven't. Crack on with the day, and it's lowered my stress levels a lot just not checking my phone.
Well, I'm extremely happy to hear that. A lot of people have had very positive reactions to that podcast, and
Good.
it's funny because there's once again so much ignorance about sleep hygiene and sleep necessity. But interesting in terms of the concept of what people define as a problem is when we think of a very classic and yet not most commonly known form of OCD, referred to as like somatic obsessions or neutral obsessions. So people who their brains make them aware of a blink, their brains make them aware of a swallow, their brains make them aware of a breath, uh, their brains can make them aware of their own nose. You met Jamie a while ago, and when I first met Jamie, that was our initial topic. That hey, I can see my nose. This isn't supposed to be happening. And it's that kind of a theme. The idea when we place rules on independent systems, like I'm not supposed to have a negative thought about a child or a friend or God. I'm not supposed to think about sex when it comes to a child. I'm not supposed to be aware of my blinks. So for a lot of people, this idea of I'm not supposed to is defined as the problem. And once again, when you define a problem as something where it is not a problem, it blows it up and it turns it into what certainly becomes problematic. The idea of trying desperately to not think about one's blinking or breathing or swallowing or the existence of one's own nose, and all of the effort and frustration and sense of loss of control and anxiety that disseminates from these misunderstandings about what is a problem. So for neutral obsessions, yes, first the theme can become, hey, I'm aware of my nose. That's not supposed to be. I'm aware of my swallowing. That's not supposed to be. And then people look at it. They mislabel it as a neutral obsession, as if like contamination, catching AIDS is not neutral. That's threatening. But awareness of one swallowing, well, that's neutral. There's no problem there. But actually, the second layer of neutral obsessions is this is distracting me. So I'm not going to be able to concentrate. I'm not going to be able to have access to my wonderful brain's capabilities. I'm not going to be able to socialize and be my entertaining, interpersonal self. And so there becomes what often people with neutral obsessions focus on as the problem is the distraction component. If every time I swallow, my brain says, you swallowed, or my brain says, when's the next swallow? Or my brain says, hey, there's saliva in my mouth. Should I swallow now? That these concepts become distracting, and then the person becomes highly distressed over the distraction component, which they then determine as being the problem. So, in terms of, remediating um, this condition, we have to show the brain, that its activity, although societally dark or what might be called inappropriate by society. I just call them creative associations and encourage my patients to call their brain activity creative associations, whether it be you know saying something blasphemous about God or inappropriate about a child or being warned about AIDS on the doorknob. That it's really critical that we show the brain that these things that the brain informs us as being problems because of the experience that gets paired with it, that we show the brain that these things are not a problem. And that's where obviously ERP comes into the picture by voluntarily, obviously, bringing up and bringing on or exposing ourselves to the things that the brain says, hey, this is a danger. And doing that repeatedly through the day, it's a very, very powerful demonstration that the brain signals are not problematic. And obviously that gets to a critical point for all therapists, for all OCD sufferers. We can't tell the brain there's no AIDS on that doorknob. We can't tell the brain, I'm not going to harm my kids tonight. We can't tell the brain, God forgives you, because the brain's malfunctioning is a physiological one. And so the physiology of OCD has no cognitive capability. So that's why we can't speak our way out of the condition. We can only demonstrate our way out of the condition by showing the brain that AIDS on a doorknob is not a problem, not because I'm not going to die from it, but because I'm willing to repeatedly engage with it, immerse myself in it, immerse myself in the thoughts by doing exposure cards on a regular and repeated basis, immerse myself in the contamination by rubbing a paper towel on a toilet seat and rubbing it all over my body and all of my possessions. That's where in the demonstration to convey to the brain behaviorally. This is not a problem because of the way I act and manage these systems rather than, you know, talk about, the underlying issue or the intuitiveness of the thought. All of those things are really just distractions from the very behavioral and physiological power of ERP, in the demonstration physiologically of the brain's malfunctioning systems and how we can override those systems through repeated demonstrations. So going back to Stu, I just want to say also, a huge component, which we've also had a beautiful episode on, is the idea of differentiating the brain voice from the gatekeeper voice. The brain voice might say, "You're a horrible person because you had that thought about harming your wife." And so that's okay that our brain voice might say, "You're a horrible person because you had that thought about harming your wife." But we then, as the gatekeeper, step in and we write the final narrative that says, "Hey, brain, I'm giving you total permission," which demonstrates irrelevance. I'm giving you total permission, demonstrating total permission to have the thought, and that I don't endorse any concepts of labeling any person as good or bad. So, brain, you can tell me all that you want that I'm a horrible person, and you can share with me all you want the idea of harming another person, because I'm not going to now react to it in a way as if it's problematic. And so, our discussion quite a while ago about sharks, sharks in the ocean, sharks in freshwater lakes, sharks in a swimming pool, and sharks in a bathtub, my favorite thing ever. That brings up, when you were, or maybe still are, challenged with these associations, Stu, where's the problem? Where's the problem with your relationship with the concept of sharks in your life?
Where's the problem? It was with my unwillingness to have thoughts and feelings about this topic. Yeah.
Right. Right.
Yeah.
And that response, shocking, is the response of someone who has tremendous education and has evolved a
Yeah.
great deal beyond being a victim of anxiety. And that's what I really despise about OCD. Um, I really hate the condition, because innocent people uh, who have not asked for this are being victimized by their broken brain and by their lack of training, which who's trained in managing anxiety, that you were victimized by your brain's signals, not only the creative thoughts about sharks in a bathtub or a swimming pool, but was it the thoughts or more the emotional component of going in the water?
Both. I always experienced the thoughts probably slightly more intense because at least it was more vivid in my head. So I shared this on a live podcast I did at the ISTF recently. I was in, obviously, and that was in Orlando, the conference this year. And, 30 years ago was when my first sort of OCD memories happened, or when I had them. And it was sharks in the pool in Florida. And that's where it all kicked off. Bathtubs came later. And this time, 30 years later, I was by myself in the pool getting a break from the conference. And I was just standing in the pool with my eyes closed, my back against the wall, just relaxing. And I was completely at peace. So it's like the change, And then I did get one intrusive thought, which was actually about a crocodile in the end, not a shark. And I just did what I needed to do and left it alone. And I think I even leaned into it like, good, can't wait, for it to eat me.
Great.
And then it went. So yeah, I just share that. It's, a change happens.
That's great. One of my favorite pictures that I've sent you is our pool. Right as you're heading toward it, there's a sign that says "Pool closed, shark sightings." I think of you every time I go to the pool. for that sign that comes up.
Yeah.
But yeah, so when you were more handicapped
Hmm.
and impaired, by your brain's creativity about sharks, I think you said the thoughts, but then I think you mentioned sort of it sounded like there was vivid images or
Yeah.
like even a video
Hmm. Yeah.
um, that was very compelling for you.
Yeah.
And it's funny because when my son was about 6 years old, I would make this iced cappuccino drink, and it involved blending this kind of chocolatey drink. And he would come over, and he'd always want to lick the spoon. And I would look down at him waiting for the spoon, and my brain would play a video of me taking his arm and jamming it into the blender and just
Hmm.
blending his bone and his meat into a pate. And then my brain played a video of his face looking up at me in this pathetic, Dad, how could you be doing this to me? And there was very compelling video that my brain was able to
Hmm.
play. And I would actually feel some heebie-jeebies, like eek, anguish. I'd
Yeah.
feel this anguish, like eek, like my body responded to this very disconcerting video. And it lasted 3 seconds. And I would just say to my brain, hey, brain, thanks for sharing. It's all good. And then just kind of go on with the day. So, it just goes to show that, our human brains, act exactly like OCD brains. I've never had a minute of OCD, but I can tell you I'm a
Hmm.
perfect candidate because every my dark thought my patients share with me, I've had at least 10 times over and a lot worse usually,
Hmm.
but without the emotional component, which is really what compels people to act in problematic ways and to disrupt their life. Um, you know, it's just brain creativity. And, 98% of the population who doesn't have OCD, reports having these kind of intrusive thoughts, but they're just very, very passing. Maybe some people think that they're evil because of it, but it's just so natural for the brain to act that way.
Hmm.
And the illusion of the problem is substantiated by the physiology generally, the experience of, hey, I've got a problem. And obviously what's interesting is that there is no memory to that physiology. So, yesterday you might have had an intrusive thought and gotten past it. And then, it seemed like, oh, that wasn't so bad. And the next day it will light up again. And the brain will say, yeah, yesterday's thought was not a problem, but this is the one
Hmm.
that's the problem because this is the one that once again feels the complete authenticity of the distress. The crisis is real. And it actually is real physiologically because there's no way for the brain machine to distinguish from an intrusive OCD thought and the emotions that come with it to actually being about to be being, let's say, bit by a shark
Hmm.
or bit by a rattlesnake, that the physiology and the way we respond to an actual life-threatening crisis and a brain's created distress signal, they're 100% equal. And there's no like, oh, this one's fake and this one's real physiologically. And that's why very intelligent people, very rational people, are so manipulated to behave in such irrational, stupid ways, to not go swimming because there might
Hmm.
be a shark. I can't help it. That just, I love that in a pool. I, it's so creative, and that you look at how compelling it must have been to keep you out of a pool. You're like,
Hmm.
I can't go in a pool because I will see the image of a shark. I'll feel the distress of a shark, and why go in a pool if you're going to have to face that crap?
Yeah. Yeah.
And
Exactly.
so, these experiences are completely authentic, but they are not a problem. And
Hmm.
people, they feel like they're a problem. People react to them like they're a problem. They manage them like they're a problem. I need to seek relief. I need to find recovery from it, safety, neutralization.
Yeah.
And that's the problem, with OCD is the degree to which people's lives are disrupted because the physiology is 100% compelling and authentic.
100%. Yeah, an extremely good magic trick, like a magician. It's done well. It's believable. It's like how that has to be something, magical going on. And then but deep down, no, it's sleight of hand. It's whatever it is. The brain, yeah, OCD is similar to that. I feel, yeah. That's all I was
So
going to say.
any follow-up comments, questions?
No, I think a phrase that's kind of been in my head since we started talking was I've definitely thought about it a bit like this before, but not massively. But the resistance makes the disorder. Because without the resistance to the thoughts and feelings, there would be acceptance, and then would there be the disorder? Because, like you said, it wouldn't probably limit people's lives because they're not.
There's that wonderful saying that goes, and I love wonderful sayings. I'm like an encyclopedia of wonderful sayings.
Yeah,
So what you're just mentioning goes, that which we resist persists.
persist. Mm.
I love that one.
Yeah, I say that to my clients all the
But
time.
it makes sense. People with OCD say, very, very sad things like, I'm a weak person because,
Mm.
I behave with fear, I behave, avoidance, escape. And it's not at all, you're behaving exactly as our physiological instincts dictate. We're programmed to get out of a cave if we hear a bear roar inside of it. We're programmed to get the hell out of that cave. We're programmed, to run out of a forest if it's on fire. We're programmed to seek safety where we experience danger. And so without the knowledge and insight to know that what's happening is a malfunctioning system, people with OCD tragically are behaving exactly as we are emotionally programmed. And it's funny, or not funny, it's tragic that, many people with OCD, and I'm sure, you must have been very upset that you're you were restricted to go swimming in a pool because of thoughts about sharks.
Mm.
To be so bewildered that everyone else is going in the pool, no one's thinking about sharks, your brain's making you think about sharks, your brain's making you feel uncomfortable, and you're not going in the pool
Mm.
because you're behaving exactly as humans are programmed. And I think that's so important, that people take away that element of shame and the element of inadequacy or the denigration of being weak. I've had about 37 panic attacks in my life. Not that I'm counting. I haven't had one in 3 years, but you know what? If one comes tomorrow, so be it. And I don't look at it in any way like, it's an example of being weak. I look at it like, my brain's physiology just sometimes goes out of whack.
Mm.
There's an imbalance, and I start to feel like I'm having a heart attack or going crazy. That's just independent systems, which I completely give license and permission to kind of react that way. So it is really important that people not think of their persona, their strength as adequate humans, based on the idea that they're fearful of very, very stupid things.
Yeah, yeah, spot on, spot on. Funny you gave the whole we're programmed to run out of forests if it's on fire. I've run out of a forest before because of OCD. Yeah, intrusive thoughts. I'm in danger. Right, get the hell out of here.
Yeah.
Yeah, but yeah, it happens. Okay, awesome. Is there anything else you want to say on this particular topic?
I was going to mention is it's
Mm.
kind of funny because I was thinking about problems differentiated by culture.
Mm.
Like in some cultures, if you hear voices and talk to spirits, you're considered like a god. You're considered a priest. In this culture, if you hear voices and talk to spirits, you're considered psychotic. I was also thinking, in England, at least historically, your culture is very, very hesitant to medicate for psychological issues. Benzos are very, very difficult to get a hold
Yeah.
of when they are prescribed. Then those are like tranquilizers, benzodiazepines like
Mm.
Xanax or Ativan or Klonopin. The English culture is like, no, there's something going on here. take a look at it, we don't need to just immediately medicate it. And it's also the same thing with the SSRIs. The British culture, is one that says, let's confront these challenges rather than medicate them away. And in America, where our pharmacological companies make lots and lots of money because our culture is, oh, you shouldn't feel bad. Take a pill. And that goes for depression, anxiety. There are many, many psychological challenges in this country that big pharma would just loves having a pill for, rather than even looking at, like something like depression. Oh, here's an antidepressant, as opposed to why are you depressed? What is it? The way you're looking at yourself, the world, your future, that's creating this depression. Our psychology, our philosophy is so much seek relief rather than seek a remedy. And that's actually the last point I wanted to make on the topic.
Yeah, yeah, we're definitely we I think I have done stats for this. I'm sure I could find them, but yeah, SSRIs we prescribe more now than we probably did historically, and that's because GPs don't have much time and they've got to make a quick decision, and they know they might be on the wait list for therapy for many months. So to help, obviously, here's a prescription. Yeah, benzos, I think we're much more restrictive just because of the addictive nature of it. And when they do prescribe it, it's more short term,
Yeah.
which I think is a good
Yeah.
thing.
Yeah. No, I am much more of a UK medication philosopher than an American one. I'm very, very um, resistant to bring medication into the system unless someone is sort of at the end of their rope and really on the verge of losing a job, committing suicide,
Yeah.
ending a marriage. Unless someone is really, really far out there, because I do believe in the human capability for recovery. Just like you were talking about being in Florida recently and enjoying the pool because you've no longer substantiated your brain's concerns about sharks.
Yeah.
Oh my God, I can't even think about it without laughing.
Yeah. It is funny. Well, it is now.
Yeah,
It
it is
wasn't.
now.
Yeah. So, all right. Thank you for that. It's a really interesting topic. So let me think. I always ask you the same questions. What's one bit of life advice you would give to 30-year-old you?
Um,
It was only last year. Come on.
yeah. Thanks for that. See, that's the nicest thing you've ever said.
No worries.
Um, I guess I would say that um, choose your relationships very, very carefully and make sure they're working for you, and in the balance of cost benefit, make sure that the balance always lands on that the relationship provides more assets and rewards than penalties and cost.
Hmm.
That's what I would tell my 30-year-old self.
Yeah. Yeah. Good advice. And then, as always, you have a billboard in New York. What do you want written on that billboard?
That anxiety is very, very treatable, and one need not take medication for it. And make sure when you do seek treatment that you truly see an expert in a scientific approach to managing things like anxiety and depression, and not an approach that promotes, just mere discussion and greater depth of insight, because those things don't tend to promote recovery.
Hmm.
That
Yeah.
was a long billboard.
All right. We can have a QR code or something.
How about the best way to get rid of low self-esteem is no self-esteem. That would be my billboard.
Yeah.
That's much more of a New York billboard.
Yeah. 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 And then lastly, anything else you wish you could have said or shared today?
No, I think we covered. I really hope that people pay a lot of attention, to the concept of what is a problem, what is the problem?
Hmm.
Because with OCD, people focus on the vast majority of the themes that are not the problem, and they attend to things that are the problem in ways that are not problematic. Like people still don't know that sometimes that ruminating is a problem, or Googling, research is a problem. So they don't, and that's really, really important that people know that it's the undoing response, like mental rumination, that, fuels the condition and wastes tons of time.
Yeah. Yeah, good point. The amount of times I've explained rumination and then you see this light bulb in their head like, oh, I didn't realize that was a compulsion.
Yeah.
It's like, yeah.
Yeah. I mean, in my Puro article in 1992, I really tried to make that point that, there's the intrusive thought and then there's the undoing response, which is mental. That's why I called it
Mm.
Puro. Both are obsessional nature by nature. And I guess the message didn't completely get through.
Yeah. Never mind. Thank you so much for coming on and sharing.
You're
As
welcome. It's
always, I appreciate it.
always a pleasure connecting with you.
Thank you for listening to this week's podcast. And thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us, please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. If you want to find out more about NoCD, head to go.treatmyocd.com/the OCD Stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.